So I want to introduce our speakers today, Dr. Laura Houston and Dr. James Carlucci. In this session on COVID-19 and special populations in obstetrics, pediatrics, and people living with HIV, we will be hearing from Dr. Laura Houston, who is an assistant professor of obstetrics and gynecology at Vanderbilt University Medical Center and is leading her department's COVID-19 preparedness and response efforts for obstetric patients. Dr. James Carlucci is an instructor of pediatric infectious disease at Vanderbilt University Medical Center. Dr. Carlucci's research focuses on improving health services for HIV-exposed and HIV-infected children in low-resource settings. I'd like to pass it along to Dr. Laura Houston now.
Okay. Hi, good morning, everyone. And we can advance to the obstetrical slides. The speakers and moderators don't have any conflicts of interest to disclose. Nice to meet everybody electronically. Thank you so much for sharing your time with us this morning. My name is Laura Houston. I'm one of the maternal fetal medicine physicians at Vanderbilt. And I'll take just a few minutes to discuss what we know about COVID-19 and the obstetrical population. There has been concern about whether or not pregnancy increases a patient's risk for worsening, more severe, or more frequent disease in COVID-19. There are multiple physiologic changes which occur during pregnancy, such as changes in maternal lung volumes, oxygen consumption, changes in cell-mediated immunity, vasodilation, which can lead to upper respiratory mucosal edema, and elevation of the diaphragm in the third trimester as a few examples. We have seen pregnant patients have increased risk of worsening disease in patients with other respiratory diseases as well. Available information for pregnancy and COVID-19 remains limited, and our practice is largely guided by information from international case reports and case series and expert opinion, leading to guidelines developed from local to national to international levels. The current perspective is that the course of COVID-19 disease is similar for pregnant and non-pregnant patients. Multiple comorbidities are known to be risk factors for more severe COVID-19 disease, such as obesity, diabetes, and underlying lung diseases. Some experience in the US suggests that these are also risk factors for pregnant patients with COVID-19. However, the magnitude of this risk remains unclear. From available information, risks of COVID-19 in pregnancy may include an increased risk of cesarean delivery and preterm birth. Next slide. Currently, there are no specific management or evaluation recommendations specific to pregnant patients with COVID-19. Largely, pregnant patients have not been included in clinical trials looking at potential treatment options, and this is limiting knowledge as well. The risk of vertical transmission remains a focus for obstetricians. There is biologic plausibility that in utero transmission is possible. SARS-CoV-2 invades cells by binding to the angiotensin converting enzyme 2 receptor or the ACE2 receptor. And that receptor has been found to be expressed in the uterus, vagina, the membranes, placenta, and fetal lung. Reassuringly, clinically, the risk of vertical transmission appears to be low from available data. COVID-19 treatment algorithms are stratified by disease severity, and reassuringly, it appears that many pregnant patients infected with SARS-CoV-2 have mild disease, recover without sequelae, and can be managed as outpatients. It is unknown if there are early warning signs for pregnant patients with COVID-19, indicating who may be more likely to decompensate. But considerations may include patients with comorbidities, high or worsening fevers, worsening dyspnea, or development of an oxygen requirement. Next slide. There have been concerns raised about nonsteroidal anti-inflammatory use in COVID-19 patients because NSAIDs increase the ACE2 expression. This has not been established as a consistent clinical concern. So low-dose aspirin can continue to be used for preeclampsia prevention and per usual indications. While many in the US may prioritize the use of nifedipine, which is a calcium channel blocker, as a tocolytic over the use of indomethacin in patients with COVID, indomethacin can be used. And ibuprofen can be used postpartum in patients who test positive for COVID-19. The use of magnesium in pregnant COVID patients should be individualized. It can still be used for fetal neuroprotection or for maternal seizure prophylaxis in patients who have mild disease. It should be used with caution, if at all, in patients with more severe disease, which may include respiratory compromise or renal impairment. Antenatal corticosteroids are being used prior to 34 weeks in COVID-19 patients to decrease neonatal complications of prematurity if there is felt to be an increased risk for preterm birth. There has been concern about corticosteroids worsening outcomes in patients with COVID-19. However, the dose and duration of antenatal steroids is felt to be a reasonable management option for stable patients with COVID-19. Late preterm steroids after 34 weeks are being avoided in COVID patients. Next slide. Nitric oxide is being avoided for all patients during the pandemic because of insufficient information about cleaning and potential aerosolization of nitric oxide systems. Oxygen is also being avoided for non-reassuring fetal tracings because of insufficient evidence of benefit and similar concerns about the cleaning and filtering of the tubing. COVID-19 should be considered in the differential for fever during labor, taking into account other clinical information and prevalence of disease in the area. Regional anesthesia can be performed and may be preferred in COVID patients early in their labor process in the event that cesarean delivery is necessary later during labor. And in COVID patients, fluid status should be monitored to avoid potential volume overload in patients with COVID. Next slide. For most patients with COVID-19, positive testing is not considered to be an indication for delivery. Most patients will have mild disease and will continue in pregnancy without complication. If patients present at 39 weeks or greater with positive testing, delivery can be considered at that time. Patients with severe or critical disease will require individualization of care. Next slide. Currently, mode of delivery is considered per usual obstetrical indications in patients with COVID-19. Cesarean delivery or operative vaginal delivery are not considered to be necessary after positive testing. Next slide. In summary, data remains limited in pregnant patients with COVID-19. Reassuringly, there does not appear to be clear evidence of more frequent or more severe disease. Management of pregnant patients with COVID-19 should be individualized by severity of maternal disease, other clinical factors such as the presence of comorbidities, and by gestational age. The risk of vertical transmission appears to be low, but cannot be excluded. And currently, mode and timing of delivery are often per usual obstetrical indications in patients with COVID-19. Next slide. And my references are the national and international organizations which are currently synthesizing information and recommendations for pregnant patients with COVID-19. And with that, I will pass along to Pediatrics.
Hi, good morning. My name is Jimmy Carlucci. I'm a pediatric infectious diseases physician and researcher at Vanderbilt. My research is primarily focused on HIV exposed and infected children. And so I'll be talking to you both about the potential impact of COVID on pediatric populations and also on HIV-affected populations. Next slide. So as a segue from the obstetrics section, I first want to just talk briefly about the care of newborns born to moms who are COVID positive. Generally speaking, these babies should receive standard care with just some additional precautions. In particular, assuming mom and baby are relatively asymptomatic enough to be together, then the recommendation is that they can room together. So again, that's assuming the baby doesn't have any complications of delivery and assuming that the mom is afebrile and able to control her respiratory symptoms. In those circumstances, we think it's safe for mom and baby to room together with a few additional precautions, those being geared towards preventing or minimizing exposure from mom to baby and the potential for spread of the virus from mom to baby. Acknowledging that many of the people listening today are in low and middle income countries where access to isolates is probably very limited. I acknowledge that the first recommendation may not be feasible, but short of having baby in an incubator or an isolate within the same room as the mother, simpler interventions like putting up a curtain between the mom and the baby to prevent spread of droplets could be considered. Of course, we would prefer that the mom and any other caregiver taking care of the baby wear masks while in the room with the baby. And then aside from when mom is providing direct care, so breastfeeding, doing nappy changes, or bathing the baby, for example, we would recommend that the mom and the baby have that barrier precaution in place, but that can be relaxed when those essential caregiving activities are being done. And I'll emphasize on the next slide that breastfeeding in particular should be continued when possible. In situations that are not so straightforward, where mom is severely ill, unable to control her respiratory symptoms, or if the baby is requiring a higher level of care, then in those circumstances, we should consider separating mom and baby. But even in that situation, we would still attempt to provide the baby with breast milk, if at all possible. I put in lighter color at the bottom of the slide, really a conditional recommendation for testing these exposed infants 24 hours after birth and 24 to 48 hours after that. That's the practice that we've been doing at my institution, though I acknowledge that it's based on very limited evidence and it also has been relatively low yield. But out of an abundance of caution, and if testing capacity is available, you could consider doing infant testing postpartum. Next slide. In terms of breastfeeding, there currently is no evidence that SARS-CoV-2, the virus that causes COVID-19, is transmitted via breast milk. That was also true of SARS and MERS, the Middle East Respiratory Syndrome, two related coronaviruses. So not only do we lack clinical evidence of breast milk transmission, but there's also biological reasons to think that that should not be an issue. So that being the case, we do recommend that breastfeeding be continued when possible because of all of the known benefits of breastfeeding for mom and baby. Again, we would recommend that occur while applying some additional precautions. So mom wearing a mask, and prior to the breastfeeding, we would encourage mom to perform hand hygiene and to wash her breasts. If mom and baby are separated, as I mentioned previously, then we would ask that mom attempt to express breast milk that could then be given to the baby even in her absence. And in the absence of that opportunity, then the alternative would be formula feeding. But of course, we'd want to ensure a good, clean, potable water source for mixing the formula. And there's also considerations of cost. Next slide. So now thinking about children more broadly, not just newborns, our knowledge about how COVID-19 impacts this population is really pretty limited. Most of the data that we have are observational reports from China. We also have growing epidemiologic data from the United States and Europe, and of course our own anecdotal experiences. But based on those available data, we think that children with COVID-19 typically have mild respiratory illnesses, so the type of illnesses you would see with pretty much any other respiratory virus, fever, dry cough, fatigue, but mild enough that it can typically be managed in the ambulatory setting. And we're learning that many COVID positive children are actually asymptomatic. So we don't really know the true burden of disease in children at this point, because until just very recently, we've not been testing asymptomatic patients. I mentioned briefly that there are some radiologic features of COVID-19 that can be seen in children as well as in adults. And that's true both in symptomatic and asymptomatic children. You can see signs of lower respiratory tract disease, but those radiologic features don't necessarily correlate with clinical disease. So in general, we don't recommend imaging as a diagnostic procedure unless it's going to change management for other reasons. Severe or critical illness in children and death due to COVID-19 seem to be very uncommon in the pediatric population, and that's especially true for those less than 10 years of age. Though in the few case reports of neonatal disease, there does seem to be greater severity. So in those less than a year of age and those older than 10 years of age, there may be more severe disease, but typically in school-age children, we see very little COVID-related disease. I'll mention briefly too, from the few case reports that are available of neonatal disease, there seem to be more gastrointestinal symptoms as opposed to respiratory symptoms. So that would be something to look out for if you had a newborn born to a COVID positive mother. And on the right side of the slide, I just have an illustrative figure that's data synthesized from the CDC, the US Centers for Disease Control. It's only current as of mid-March, so it's very out of date at this point, but the proportions illustrated are still hold true. So at the top, you can see the 0 to 19-year-old age group. At the bottom, it goes up to the greater to 85-year age group. And then the pink bars are hospitalization rates, the red bars are ICU admissions, and the black bars are case fatality rates. And so when you look at the group of children, the very top window, you can see that children really aren't very severely affected. The vast majority can be cared for in the outpatient setting. Next slide. In terms of treatment, really considering that children generally have mild disease, the mainstay of treatment is supportive care. For those who are critically ill, that's that small subset who are critically ill, or for those who have immunocompromising conditions and the potential for becoming critically ill, antivirals can be considered on a case-by-case basis, preferably as part of a clinical trial. But frankly, the need to do this should be pretty uncommon. And if you do find yourself in a situation where you're considering starting antivirals for a severe case of COVID-19 in children, then that should be done in consultation with a pediatrician or an infectious disease specialist. In terms of the drugs that are potentially available, remdesivir seems to have the most data to support its use, though accessing this drug, especially in low and middle income countries, is probably near impossible. We're having difficulty accessing it even in the United States at this point. And the other drugs really lack data, especially in pediatric populations. So all of these should be used with extreme caution in this population. Next slide. Some other pediatric considerations. First, another few thoughts about immunocompromised children. Of course, there's a theoretical risk that children with immunocompromising conditions, especially those with lymphopenia for a variety of reasons, are potentially at higher risk for viral infections in general. So you would think that they would potentially be at higher risk for COVID-19 as well. Though this has not yet really panned out in our experience. The available data doesn't seem to show that immunocompromised children are any more severely affected than the general population of children. And that includes our experience with cancer patients, those receiving chemotherapy, those who've had transplants, those with primary immune deficiencies, those who are on immunomodulators. So far, we've not really seen more severe disease in those subgroups. When we do see severe disease in an otherwise healthy child, though, I do think it's important that we consider whether or not that child might have an underlying undiagnosed immunocompromising condition, because it is so atypical to see severe disease in young children. In terms of childcare and schools, most countries at this point have closed childcare facilities and schools with concern about children being a reservoir for transmission to other vulnerable populations. From a public health perspective, this is probably a reasonable thing to do, but I do think that these types of recommendations need to be very carefully considered, especially in low and middle income countries where educational opportunities can be very limited, and disrupting these educational opportunities can really potentially limit a child's long-term potential. And on top of that, I think we have to also consider what is the alternative. If these children aren't in a childcare situation or at school, where will they be otherwise? Will they be in a household with elderly caregivers who are potentially at higher risk? So it's not a straightforward issue, unfortunately. Next slide. Briefly, there have been concerns about fecal viral shedding. So we know that SARS-CoV-2 can be detected in the stool of COVID positive children. But so far, the data seem to suggest that a virus that we detect in stool is probably not replication competent, or in other words, it's probably not infectious. That said, there is uncertainty, so of course we recommend hand washing after diaper changes, though that's a recommendation that I think we would make regardless of COVID-19. We also have been seeing co-infection with other common respiratory pathogens. So identification of another pathogen certainly does not exclude the possibility of COVID-19. And if we do see severe disease in children, I would be reticent to attribute it entirely to COVID-19, and I would consider the possibility about there being perhaps another co-infection that's driving the severity of illness. And then lastly, just one brief bullet on what I think could be an entire presentation in and of itself, is that I worry that there are potentially very important and severe indirect consequences of COVID in the pediatric population. As I've mentioned previously, the direct consequences are probably minimal, but in populations where there are already high levels of poverty, food insecurity, limited educational opportunities, sometimes poor uptake of immunizations and other health services for potentially life-threatening illnesses, to then have the COVID-19 pandemic create even more instability in all of those areas is very concerning for child health. So I think we need to be vigilant about thinking about these indirect consequences. And the UN recently published a policy brief that goes into great detail on all of these issues. I would encourage everybody to read it if they're taking care of children. Next slide. So to summarize, we would recommend that additional precautions are implemented for newborns and breastfeeding infants of COVID-19 positive mothers. But generally speaking, those babies should also receive standard care. So again, we would recommend that they breastfeed when possible, and that they should continue to get recommended services like immunizations. Most children with COVID-19 have mild symptoms, if any at all, and supportive care is the mainstay of treatment for the vast majority of children with COVID-19. And then just a quick quote from that UN policy brief that I mentioned on the previous slide. that I think summarizes this well. Children are not the face of this pandemic, but they risk being among its biggest victims. Next slide. Some quick references. The third one in particular is a clearinghouse for many different references relevant to maternal and child health in the context of COVID-19, and really all focused on care, clinical care in low and middle income countries. That link will get you not only to the UN policy brief that I mentioned, but many other resources. Next slide. Next slide. So moving on to the potential impact of COVID in HIV-affected populations. In this section, I've organized just as a series of questions that I think many providers are probably considering. So the first is, are people with HIV at greater risk for COVID-19? And the short answer is we don't know. There's limited data on COVID in HIV-positive populations. That being said, I think low and middle income countries with higher prevalence of HIV really have great potential to inform this question. So we'll benefit, I think, from your experience and reports moving forward. And I will say too that the paucity of data to some extent has to do with exclusion from prospective studies. Many studies are including HIV positive patients, and I think that's a very good thing in general, but because of concerns about antiretroviral therapy and protease inhibitors like Kaletra in particular, potentially confounding results of clinical trials, some have opted to exclude HIV positive patients. So all said, the educated guess in response to this question of are people with HIV at greater risk is that for those who are adherent to antiretroviral therapy and who have relatively normal immune function, we suspect that they will be at no higher risk than someone without HIV. Whereas those who have impaired immune function, so those with AIDS, for example, are likely more vulnerable. But we really just don't know. And then a final thought is that many of our HIV positive patients are aging and have comorbid conditions. And so while HIV may not be a risk factor in and of itself, we do need to be considerate of the possibility that HIV positive persons have other underlying conditions like smoking and hypertension, diabetes, things that will put them at risk for COVID complications. Next slide. So how is the HIV management changed in the setting of COVID-19? I think in an ideal situation, it wouldn't be changed much, but the reality is we've pretty severely limited access to healthcare settings for non-emergent situations at this point to minimize potential exposure to COVID-19. And so because of that, there are some potential changes in how we approach the management of HIV. So the first thing I'll say is that in higher resource settings like the United States, we've converted many of our visits to telehealth, and we've also moved to delivering antiretrovirals directly to patients' residences rather than asking them to come to the pharmacy or to the healthcare setting to get those services. I acknowledge that neither of those may be feasible in low and middle income countries. But if a patient has a smartphone, for example, then this may be an option. I think more relevant is the potential to leverage and accelerate the implementation of differentiated models of care, some of which are already being implemented to some extent for the delivery of HIV care in low and middle income countries. And so those include things like multi-month dispensing of antiretrovirals rather than just giving 1 month of medications at a time. Leveraging community adherence groups. So these are groups where potentially a family unit or a community group of HIV positive persons sends one representative to the clinic to pick up medications for the entire group. Both of those with the goal being to minimize exposure to the healthcare setting in the context of this pandemic. Another potential strategy is to defer routine labs for patients who are otherwise stable. And I think we can safely do that for those who have demonstrated good adherence and who have documented viral suppression. We can also potentially do this for patients who are receiving PrEP for the prevention of HIV. Next slide. Are there any recommended changes to antiretroviral therapy in the setting of the COVID pandemic? The short answer is no. There's very limited data to support the use of antiretroviral medications for the prevention or treatment of HIV. Lopinavir, ritonavir, or Kaletra, I think a lot of people had hoped that it could be repurposed for use in COVID. But the data that we have available so far does not really support it as being an effective intervention. There was recently a randomized controlled trial published in the New England Journal of Medicine that randomized patients either to lopinavir, ritonavir, or standard of care. And there were really no significant differences in terms of clinical improvement, mortality, or virologic outcomes. And in fact, those who were receiving lopinavir, ritonavir, 14% had to stop early because of adverse events. So there's potential for harm. Next slide. And these are just a couple of figures from that paper that show the lack of clinical and virologic benefit of lopinavir, ritonavir. Next slide. Are there any recommended changes to antiretroviral therapy specifically? Again, the short answer is no. We would not recommend changing someone to a Kaletra-based regimen. We would not recommend adding Kaletra. We don't have any evidence that any other protease inhibitors would provide additional benefit either. Remdesivir, which does have some potential for efficacy in those who have COVID, is a nucleoside analog. So the question has been raised whether other nucleoside analogs used for treatment of HIV might have some effect. But so far, there really is no data to support doing that. So at this point, we're not recommending any changes to antiretroviral therapy. And what we do know about changes in ART is that there's potential for side effects and toxicity, which can be especially problematic in low and middle income countries where there's limited capacity for monitoring, even more limited in the setting of COVID. So that would be a reason not to change, not to mention the lack of evidence. And there are also concerns that changing to a non-evidence-based antiretroviral regimen could put a person who otherwise had good control of their HIV into a situation where they don't have optimal control. And of course, anytime you're introducing new medications, there's the potential for new drug resistance mutations developing in the setting of non-adherence. So we'd want to be very cautious about that as well. Next slide. Are there different treatment protocols for those with HIV compared to the general population? And again, the answer is no, primarily because the treatment protocols that are available for the general population are based on very limited evidence. So to suggest that there should be deviations from those protocols based on HIV status where there's even less data is probably not a good idea. And as I mentioned previously, as of now, we don't have any evidence that those with HIV are any more severely affected than the general population anyway. So if there are considerations about rationing services, for example, if there are a limited number of ventilators, the general recommendation from the HIV Medicine Association and the IDSA, the Infectious Disease Society of America, is that HIV status should not be a consideration in deciding how to allocate those resources. Things that can be considered, though, are prioritizing testing for those who have HIV, given the theoretical risk, at least for more severe disease. And as with any of our patients with comorbid illnesses, we should really reinforce the importance of prevention. So social distancing, hand washing, and masks. Next slide. So what do clinicians without HIV expertise need to know about treating HIV and COVID patients? This is a busy slide, but the short answer is they need to know two things. One is that they should go to whatever extent necessary to ensure continuation of antiretroviral therapy for these patients. We would really want to make sure that antiretroviral therapy is not interrupted for patients who are otherwise stable and doing well on antiretrovirals for the treatment of their HIV. And two is that for those who are HIV positive but not yet on antiretroviral therapy, we should consider starting it when they access care for COVID. Whether or not that is started immediately or if it's deferred until a hospital discharge, it has to be an individualized decision because there are some theoretical risks of starting antiretrovirals in the setting of an acute respiratory infection. But if there's uncertainty about this, I would strongly encourage folks to consult with someone who has HIV expertise. Next slide. So to summarize, it's unclear whether people with HIV are at greater risk for COVID. Strategies for ensuring continuation of antiretroviral therapy while minimizing interactions with the healthcare system should be further explored. And so that's, again, things like leveraging differentiated models of care. We should not be making COVID-19 management decisions based on HIV status at this point in time. We just don't have the evidence to support that. And a final thought is that we've really made great progress in the diagnosis and treatment of HIV, especially in low and middle income countries. And so the goals of sustained retention and care, ART adherence, and optimizing health outcomes for populations with HIV still remain incredibly important. So we really need to remain vigilant to prevent COVID-19 from mitigating this progress. Next slide. So here are some references. And I think that wraps it up. So I would probably move on to questions. Thank you.
Thank you so much, Dr. Houston and Dr. Carlucci, for those really interesting presentations and lectures. We're going to be passing it along now for Q&A. I do want to just highlight again to please put any questions into the group chat. You're welcome to introduce yourself that way, and we will be taking questions there. I'm going to pass it along to two additional colleagues now to take questions and answers. Dr. Matt Kynes, who's going to moderate the questions and answers, is an assistant professor of pediatric anesthesiology at Vanderbilt University Medical Center, where he also directs global health training programs for anesthesiology residents and fellows, and is involved in research and education for anesthesia providers in East Africa. He's also joined by Dr. Christopher Sizemore. Dr. Sizemore is an assistant professor in the Department of Obstetrics and Gynecology at Vanderbilt, and also directs the department's global health section. So Dr. Kynes, I'll pass it along to you now.
Great. Thank you, Monica. And thank you again to Dr. Carlucci and Dr. Houston. I want to start with a couple of questions that were sent in and have Dr. Houston as well as Dr. Sizemore weigh in on some OB practices. First, there were a couple of questions very practically about precautions with PPE and other protocols in place for nursing staff and other providers taking care of mothers during labor for either a suspected or even an asymptomatic patient. What precautions have you put in place or recommend to protect staff in that situation?
Yes, so for patients that are either being tested for COVID or have tested positive, we're doing gowns, we're doing gloves, masks, and eye protection as well. And then we're reserving the N95 masks for people with confirmed cases. And that includes both, all providers that would interact with the patient.
Thank you. What about screening and testing procedures for mothers who are coming in for delivery?
So at Vanderbilt, we actually transitioned within the last few weeks to testing all pregnant patients that are coming in. I don't know how long we will continue to do that. Obviously, that's a challenge between availability of resources and how to use that information clinically. But right now, we actually are testing patients that are admitted.
And Matt, I'll add too, we've had mixed response to that. Patients can obviously opt in or opt out of that testing. We've had some patients who've declined testing for various reasons. There's sometimes cost issues or privacy issues, but That's a new policy that we've been doing for about a week now, and we're also trying to investigate our asymptomatic carrier rate, of course. So that's new for us, but that's what we're doing on our unit now. Anyone who's admitted is tested.
Any idea on what the asymptomatic mother rate is? Have you measured that?
I have not heard the prelim data. Have you, Dr. Sizemore?
The numbers I saw come out yesterday that were released from our departmental email down was, I believe, 130 tested and 1 positive asymptomatic. And some of the numbers that we'd seen previously were in the 6%, 5%. So I bet we're going to end up somewhere in that low number. But since it's so new, it's really hard to get any accurate numbers. But that was what the information that we had yesterday.
Yeah, I'll just chime in there as well. I think what we can say is that there's limited information, and the information we have seems to vary a lot from setting to setting. And so in a place like Nashville, where there's not been a large peak, the yield of testing asymptomatic patients has been pretty low. So like Dr. Sizemore said, in adults, which I think includes pregnant women, I shouldn't say I think, which includes pregnant women, the yield has been less than 1%. And in children, it's essentially been 0. That's our experience at Vanderbilt. Whereas in New York, I've heard rates as high as 15% among asymptomatic pregnant women. So I think it's going to vary a lot, and it's going to depend on what the epidemic looks like. And of course, the decision about whether or not to implement asymptomatic testing is going to depend on capacity. And so in a lot of resource limited settings, that just may not be feasible.
So in that case, Dr. Carlucci, screening questions would be critical to help to identify symptomatic patients in a setting where you suspect the asymptomatic rate may be very, very low.
Yeah, and getting back to the concern about exposure to healthcare providers who are then going to be interacting with other patients and the implications on PPE and everything else. There certainly seems to be some asymptomatic transmission, but I think, and we can't say this with certainty, but we think that those who are symptomatic are probably much more likely to be transmitting the virus. So I think there will continue to be an important role of symptom-based screening and having that continue to inform who gets tested.
Great. Want to ask a couple of pediatric questions. And Dr. Carlucci, there have been some reports recently of a rare systemic inflammatory syndrome and some other atypical presentations in pediatrics. Do you have any comment on that, what that might be due to or how providers should approach that?
Yeah, it's something our pediatric infectious disease community has been talking a lot about. There's been a lot of buzz on our listservs, and even within our own division, it's something that we've been discussing. I and our group at Vanderbilt has not yet seen that. That on the other hand, we have continued to see cases of Kawasaki disease, for example, where patients were COVID negative. So I think, again, getting back to the epidemiology, there are few severe cases among children, and that includes rare manifestations like this inflammatory condition. We don't know for sure, but with Kawasaki disease, again, we think of it sort of as the common final pathway of probably a lot of different triggers, some of which are probably common respiratory viruses. So it stands to reason that a novel human coronavirus could probably trigger that same inflammatory cascade. We do see, it seems that to be a sort of a hyper-inflammatory response in adults with COVID-19 as well. So I think it stands to reason that this could be a manifestation in some children who have symptomatic disease. But in terms of how best to identify it or management, I just really don't think we know the answer to that yet. At this point, I think if we were to see a case like that, we would probably manage it similar to how we would manage any other child with Kawasaki disease. So with anti-inflammatory medications like IVIG or steroids.
Interesting. Thank you. There was a question about why the presentation is so much more mild in children, and we probably don't know entirely, but would be interested to hear your comment, especially in light of the fact that children can have severe complications from influenza and RSV and other respiratory viruses. What's your thought or opinion on that?
Yeah, and I would go even further to say they can have severe disease to other human coronaviruses. So why this one in particular does not affect children and really young adults, for that matter, in the same way that it affects older adults, is really not known. It seems that there is probably something to do with, the host and pathogen interaction. So there's probably something different about the pediatric host and the adult host, but what that difference is, we don't yet know. One thing I'll say as well is that we also saw this phenomenon with SARS-CoV-1, so the original SARS virus, and we've also seen that with MERS. Children just don't seem to be affected by these particular coronaviruses, but why that is, we don't know.
Another question about pediatrics. Just to clarify, are there any risk factors, lung disease, congenital cardiac disease, asthma, et cetera, that may contribute to children who would be at risk for presenting with more severe symptoms?
Yeah, at this point, we don't know. We're certainly treating those patients with those comorbid conditions more cautiously. We're reinforcing prevention measures in those populations more aggressively. But frankly, we've not seen more severe manifestations in those groups. And I can tell you just anecdotally, we've had a heart transplant patient recently who was COVID positive, who was managed in the ambulatory setting despite, being on an aggressive immunosuppressive regimen. So it's not clear that these children will be more severely infected. But I think considering the theoretical risk, we should be cautious.
Thank you. This question about drug-drug interactions between remdesivir and other NRTIs that patients with HIV may be taking. Any comment or thoughts about how that might be managed?
No, sorry. Unfortunately, I don't have any direct knowledge on that. If I were going to use remdesivir in an HIV patient who was on other nucleoside analogs, I would probably have a conversation with one of our clinical pharmacists. And if one of our providers on the call today find themselves in a situation where they are going to use remdesivir, then I would encourage them to reach out to someone like me, who could potentially help them find that information. But I haven't personally had to navigate that scenario yet, so I don't know.
Okay. Dr. Houston, another question about management of laboring mothers who are receiving nitrous oxide for analgesia, as well as oxygen use for neonatal resuscitation. Could you comment on any variations or modifications to standard processes for those patients?
Yeah, on the national level in the US, there has been consensus to avoid both nitrous and oxygen for fetal resuscitation for non-reassuring tracings for actually all patients during the pandemic. So we're not really stratifying that by positive status or by symptoms, but we're actually avoiding that for all patients right now. It's just there's unclear data about with nitrous, the risk of aerosolization, and with both, the risks with the tubing and the cleaning and how effective that might be with this particular virus.
Good, thank you. Dr. Carlucci, there's a question about convalescent plasma, and it may be too early to answer for sure, but what role might that play in helping to manage patients with severe presentations of COVID-19?
Yeah, I think it has promise, but it's too soon to say. There are ongoing clinical trials, so I think we'll just have to wait and see.
Okay, thank you. And then one other question for you. You mentioned testing in exposed infants twice. What's the rationale behind that?
Yeah, this question came up yesterday as well, and unfortunately I don't have a good answer, and I also was not a part of the committee who made that recommendation. I don't want to say it's a bad recommendation. It's something that's being done out of an abundance of caution and considering relatively easy access to testing here at Vanderbilt. But the yield has been incredibly low. And from what we know, both from the literature and our anecdotal experience so far, is that newborns, even if positive, typically don't have severe disease. So I'm not going to go so far as to say that people should be testing newborns who are exposed to COVID-19. If there are resources to do so, then that very cautious practice certainly is defensible, but it's not an evidence-based practice.
Okay, thank you. Well, we are getting to the end of our time for discussion. I know Dr. Houston had to step away, but Dr. Sizemore and Dr. Carlucci, just want to give you a minute each to provide any closing remarks, and then we will pass back to Monica to close the session. And for anybody who wants to continue the conversation, please join the WhatsApp group to do that.
Perfect. I'll just jump in. Thanks, Dr. Kynes, Dr. Carlucci, and Dr. Houston is giving another grand rounds for our department right now. So she's the expert for us and has done a great job presenting this and disseminating information to our department. The two things I would say to our African colleagues to remember from a clinical standpoint in obstetrics, which we've been dealing with in our own department, is the confusion of preeclampsia in COVID patients and then intrapartum fever. So the preeclampsia, some of the lab abnormalities seen in COVID can mimic preeclampsia. So the thing I would recommend everyone just look out for a patient that potentially could be missed, that could have COVID, and the elevated liver function test may be from COVID or from HELLP syndrome. So just always remember the lab abnormalities, and the presentation can be very confusing, especially in the initial stages. And then secondly is intrapartum fever. So when a patient's in labor and comes into the unit, sometimes the labor could be 24 plus hours and they come in asymptomatic and then develop a fever during labor. And that could either be intrapartum fever, chorioamnionitis, or it could be an evolving COVID. So those are the two situations clinically that we've seen at Vanderbilt that have been very confusing, and potentially could be situations where patients were missed and COVID patients were not treated appropriately and to protect the staff. So keep an eye on those lab abnormalities in COVID and preeclampsia, and then intrapartum fever management to make sure you're not missing a potentially evolving COVID patient. And thank you all very much. I know everyone on this call is passionate about protecting moms and babies, and so we all appreciate that. And I hope this information provided will help you guys all in your hospitals and communities care for your patients. Thank you very much. And Dr. Carlucci, on to you.
Yeah, so I have really just two sort of closing thoughts. One is in response to something I'm seeing in the chat box here from Insala in Ouagadougou, I think, if I'm pronouncing that correctly, asking about how to provide HIV prevention and treatment services in the setting of COVID, and sensitive to stigma that already exists. I don't have the answer to that question, but I think there are many similar questions, and I think the answers are not going to come from people like me. I think the answers are going to come from people like the person asking the question and others participating on this call. These are really complex issues, and I think the solutions need to be local and regional to some extent. Certainly there are public health measures that make sense in terms of stemming COVID, but they, I think, need to be balanced against very important, some other very important individual and public health considerations, and HIV is one of those. So as I mentioned in the presentation, it would be an absolute shame, I think, if all the progress made in the fight against HIV is set back because of COVID. We really, I think, need to be thoughtful about how to best continue to deliver those really important services. And then with children in mind, we know that in low and middle income countries, especially in Africa, children are at risk, at much higher direct risk from malaria, pneumonia, diarrheal illnesses than they are to the direct consequences of COVID. So I think we still need to be really focused on making sure children receive services that prevent them from getting those other diseases. So making sure malaria prevention measures are still being distributed, making sure that children are getting recommended immunizations, et cetera, et cetera. Because my fear for the pediatric population in particular is not so much about the COVID itself, but the indirect impacts of COVID, the impact on the caregivers of these children and the trickle-down effects that that's going to have on the health of their children. And again, I don't have the solutions to those problems, but I think I think it's important that myself and others work with people like those who are participating in this call to come up with those local and regional solutions. So thank you for letting me participate.
Great. Thank you so much. I recognize that we're over time, so thank you to Dr. Houston, Dr. Carlucci, Dr. Sizemore, and Dr. Kynes for this wonderful session. Again, apologies to everyone that we had to change the Zoom link at the last minute. Unfortunately, these things happen. But to anyone who couldn't access French interpretation, we will have this recording translated into French and available on the Assist International and the Vanderbilt website later on, as well as we will post the presentation and the English version of this, or the English recording of this session on our websites as well for a larger audience. I want to thank the entire Vanderbilt team, as always, a wonderful session, as well as GE Foundation for making this possible. And I'm going to pass this along to my colleague Claire to explain the WhatsApp group.
Hi, everyone. Thank you again for all of the questions that you submitted, and we know that there may be more questions. So we invite you to join our WhatsApp group. You can ask your questions there in the group. We have several faculty members from Vanderbilt who are in the group and who are available to answer your questions. Also, you can feel free to share information about what's happening with COVID-19 in your setting. So you can scan this QR code with your camera to join the group. We'll also be sending the link out through email if we have your email address. If you have any trouble joining the group, please email us at echo@assistinternational.org. Thanks.